Abdominal compartment syndrome, Budity plus NCBI 2023 article. Abdominal compartment syndrome (ACS) is a serious condition that occurs when the pressure in the abdominal cavity rises above 20 mmHg and causes end organ damage. Persistently elevated intra-abdominal pressures (AP) can cause long-term organ dysfunction and can be potentially fatal if not promptly recognized and treated. Definitions: 1. Normal lap 5-7 mmHg. 2. Intra-abdominal hypertension, IAP, 12 mmHg. According to World Society of Abdominal Compartment Syndrome, IAH can be graded as further, grade L, IAP 12-15 mmHg, grade EL, IAP 16-20 mmHg, grade L, IAP 21-25 mmHg, grade IV, IAP 25 mmHg. 3. Abdominal compartment syndrome, IAP, 20 mmHg with new organ failure. A causes of IAH and ACS can be broken down into the following categories. 1. Diminished abdominal wall compliance, abdominal surgery, intra-abdominal adhesions, major trauma, major burns, mechanical ventilation, obesity. 2. Increased intraluminal volume, gastroparesis, gastric distension, ileus, constipation, toxic megacolon, volvulus. 3. Increased extraluminal abdominal volume, hemoperitoneum, pneumoperitoneum, severe pancreatitis, liver failure with ascites, retroperitoneal or intra-abdominal tumors, intra-abdominal abscesses, laparoscopy with excessive insufflation pressures, peritoneal dialysis. 4. Capillary leak fluid resuscitation, damage control surgery, bacteremia, systemic inflammation, coagulopathy, sepsis, massive fluid administration, blood product transfusion, measurement of intra-abdominal pressure. 1. Direct, intraperitoneal needle catheter. 2. Indirect, intravesical bladder, intragastric, intrauterine, or rectal routes. 3. Bladder route via Foley catheter is most common. Measurement technique. 1. Instill 25 ml sterile saline into bladder. 2. Measure pressure at end expiration, 1 minute after installation. 3. Ensure relaxed abdominal wall and no straining coughing. Pathophysiology. Elevated intra-abdominal pressures can affect multiple organ systems, including the cardiovascular, respiratory, renal, gastrointestinal, and nervous systems. Key mechanisms. 1. Elevated intra-abdominal pressure IAP, 20 mmHg. 2. Compression of abdominal organs and vasculature. 3. Reduced blood flow and perfusion to abdominal organs. Organ-specific effects. 1. Gut, ischemia, mucosal damage, bacterial translocation. 2. Kidneys, decreased CO causes decreased renal perfusion, decreased urine output, acute kidney injury. 3. Lungs, diaphragmatic splinting, atelectasis, respiratory failure. 4. Brain, increased LCP due to decreased venous drainage, potential for neurological damage, overall impact. 1. Multi-organ dysfunction. 2. High mortality if left untreated. Treatment goal. 1. Reduce lap and restore perfusion to abdominal organs. Management of abdominal compartment syndrome ACS. Aim of measurement is to restore organ perfusion. 1. Maintain abdominal perfusion pressure APP, 60 mmHg. 2. APP equals mean arterial pressure, MAP, intra-abdominal pressure. AP, V. Non-surgical and surgical interventions. 1. Reduce intraluminal volume, A. Nasogastric decompression, B. Rectal tube decompression, C. Endoscopic decompression. 2. Percutaneous drainage for extraluminal volume ascites, hematoma. Improve abdominal wall compliance, A. Adequate sedation and neuromuscular blockade, B. Remove constrictive dressings, C. eschar release. 3. Other recommendations: A. Optimize fluid administration, B. Use hypertonic products or colloids, C. Consider hemodialysis or ultrafiltration, D. Goal-directed resuscitation. 4. Surgical decompression. 1. Emergent laparotomy if conservative management fails. 2. Rapid improvement in organ dysfunction. 3. Abdominal fascia may be left open temporarily. 4. Negative pressure dressing system to minimize complications. Complications of surgical decompression. Sudden cardiovascular collapse at induction is very likely. 1. Fistula formation. 2. Protein loss. 3. Abdominal wall retraction with ventral hernia. 4. Wound infection. 5. Recurrent ACS up to 20%. Timing of surgical decompression. 1. Debatable. 2. Consider surgery when conservative management fails. 3. Balance benefits and risks of surgery. Eisenmenger syndrome. Eisenmenger syndrome is a form of cyanotic congenital heart disease that includes pulmonary hypertension with bidirectional shunt or right to left shunt, associated with either 1. Aortic level e.g., patent ductus arteriosus. 2. Atrial level e.g., atrial septal defect. 3. Ventricular level e.g., ventricular septal defect. This condition is often inoperable. With advances in medical therapy, patients can live into their 30s. When these patients require incidental surgery, anesthetists and surgeons must understand the pathophysiological changes to provide safe perioperative care. Pathophysiology of Eisenmenger syndrome. 1. Decreased pulmonary arteriolar bed cross-sectional area. 2. Irreversible pulmonary hypertension. 3. Elevated pulmonary vascular resistance. PVR persists or worsens after surgical closure. Hemodynamic changes. 1. Balanced shunt with equal pulmonary and systemic vascular resistances. 2. Right to left shunt increases with A. Increased PVR, B. Decreased systemic vascular resistance, SVR, C. Factors exacerbating pulmonary hypertension, hypercarbia, acidosis, hypoxia, high left atrial pressure, high pulmonary blood flow. Management implications. 1. SVR responsive to physiological and pharmacological influences. 2. Decreased SVR worsens right to left shunt and hypoxemia. 3. Increased SVR may increase left to right shunt and pulmonary blood flow, but worsens pulmonary hypertension. Clinical considerations. 1. Patients may present for incidental surgery or during pregnancy. 2. Understanding pathophysiology crucial for safe perioperative management. 3. Avoidance of factors worsening pulmonary vascular resistance. Anesthetic considerations for Eisenmenger syndrome. 1. Maintain cardiac output and systemic vascular resistance, SVR, to avoid hypotension. 2. Avoid factors reducing cardiac output, myocardial depression, extreme heart rate changes, decreased venous return. Anesthetic techniques. 1. Heavy premedication well tolerated, use minimum induction agent dose. 2. Antibiotics for infective endocarditis prophylaxis. 3. Avoid paradoxical air embolism, induction agents. 1. Use caution with barbiturates and alphazine due to hypotensive effects. 2. Consider ketamine, etomidate, or midazolam for stable hemodynamics. Maintenance. 1. Opioid anesthesia suitable. Add low-dose volatile agents for awareness prevention. 2. Avoid excessive transpulmonary pressures during IPPV. Muscle relaxants. 1. Choose atracurium or vecuronium for minimal cardiovascular effects. Regional anesthesia. 1. General anesthesia often preferred due to risks of hypotension with spinal or epidural blockade. Fluid management. 1. Careful fluid replacement. Avoid volume overload and extracellular fluid loss. 2. Replace blood loss with colloid or crystalloid solution initially. Monitoring in Eisenmenger syndrome. 1. Controversy surrounds invasive monitoring due to additional risks in these patients. 2. Risks include A. Postcannulation thrombus formation with intraarterial catheterization. B. Infection and paradoxical air embolus with central venous catheters. 3. Pulmonary artery rupture, arrhythmias, and embolization with pulmonary artery catheterization. Recommendations. 1. Intraarterial monitoring recommended for all patients to closely monitor blood pressure. 2. Central venous catheter considered useful but not mandatory for managing venous return and shunt dynamics. 3. Pulmonary artery flow-directed catheter may be beneficial in specific cases, e.g., interatrial or aortopulmonary communication, but risks may outweigh benefits in others. Removal of monitoring devices. 1. Remove invasive monitoring devices when no longer providing useful information to minimize complications. A. Pregnancy and Eisenmenger syndrome. 1. High maternal mortality 27%. 2. Fall in systemic blood pressure increasing right to left shunt. 3. Thromboembolism compromising pulmonary circulation. 4. Increased blood volume and high hematocrit. Delivery considerations. 1. Vaginal delivery preferred over cesarean section due to unpredictable blood loss risks. 2. Epidural block recommended for analgesia if hypotension is avoided. Thromboembolism prevention. 1. Anticoagulant therapy not advised due to risks of life-threatening hemoptysis and bleeding complications. 2. Early ambulation considered a key measure to prevent thromboembolism. V. Postoperative care. 1. Rapid return to consciousness. 2. Avoid hypoxia to prevent increased pulmonary vascular resistance. 3. Maintain stable heart rate. 4. Oxygen therapy. 5. Early mobilization, perioperative myocardial ischemia and non-cardiac surgery, preoperative considerations and management, a risk evaluation using scoring systems e.g., Lee's Revised Cardiac Risk Index. To predict major, adverse cardiac events, Lee's Cardiac Risk Index is only validated for elective surgery and does not encompass all risk factors for major adverse cardiac events. B. Identify high-risk patients with factors such as 1. Recent myocardial infarction. 2. Recent coronary stent insertion. 3. Elevated preoperative troponin L. 4. Valvular heart disease. 5. Decompensated heart failure. 6. Arrhythmias. Patients with 3+ clinical factors may require further assessment of myocardial perfusion and function. V. Overall goal: prevent and manage perioperative myocardial ischemia to reduce 30-day mortality. A. Recent PCI. Increased risk of in-stent thrombosis. Delay elective surgery based on stent type. Consider multidisciplinary discussion for urgent surgery, and continue aspirin when possible. These considerations aim to balance bleeding risk with the risk of thrombosis. A recent MI. Delay elective surgery for at least 60 days post-MI to reduce risk of reinfarction and mortality. Surgery within 30 days of recent MI has almost 6-fold increased risk of reinfarction compared to delayed surgery after 2 months, 32% versus 59%. Delay surgery by 6 weeks post-MI. Optimization. A. Non-invasive cardiac stress testing, stress echo, exercise testing, or other methods may be used to evaluate cardiac function. 1. Considered for patients with poor functional capacity, 4 METs, and high perioperative risk. 2. May not be necessary for patients with excellent functional capacity, 10 METs. A. Coronary revascularization. Coronary revascularization may be indicated in patients with extensive stress-induced ischemia. 1. Indication similar to non-perioperative setting. 2. No benefits shown for prophylactic revascularization in stable or asymptomatic coronary artery disease. B. Preoperative diagnostic angiography, indicated in patients with acute STEMI, NSTEMI, unstable angina, high-risk surgery. C. Pre-operative CABG indicated in 1. Left main stem disease, 50% stenosis. 2. DVCAD or TVCAD with 70% stenosis. A. Perioperative medications. 1. Beta blockers, continue in patients already taking them, starting de novo is uncertain. 2. Aspirin, continue or stop based on individual risk of bleeding versus thrombotic complications. 3. ACI SARBs, based on guidelines, American, continue or European, discontinue if used for HTN. 4. Statins, continue in patients already taking them, consider initiating in vascular surgery. Patients, AA anesthetic management, intraoperative considerations. Physiological goals. 1. Maintain myocardial oxygen supply-demand balance. 2. Factors to consider. 1. Oxygen content. 2. Coronary blood flow, diastolic time, blood pressure. 3. Heart rate. 4. Myocardial contractility, key strategies or goals. 1. Oxygen, maintain normal oxygen saturations with lowest possible FiO2. 2. Heart rate, avoid tachycardia with analgesia and beta blockers. 3. Transfusion thresholds, A. Restrictive threshold 70 gl, for most patients, B. Liberal threshold 80-100 gl, for patients with acute coronary syndrome or high risk. 4. Temperature control, maintain normothermia to reduce cardiac events, anesthetic technique and monitoring. 1. No specific anesthetic technique proven to prevent myocardial ischemia. 2. general, neuraxial, or regional anesthesia have similar outcomes. Intra-op monitoring. 1. ECG with precordial leads for high-risk patients. ECG lead sensitivity varies based on combinations. Here's a breakdown. Single lead sensitivity, lead V4, 61% sensitive while lead V5, 75% sensitive. Multi-lead combinations, leads EL and V5, 80% sensitive, leads V4 and V5, 90% sensitive, leads I, V4, and V5, 96% sensitive. 2. Blood pressure measurement, invasive for high-risk patients. 3. Transosophageal echocardiography, TO, for hemodynamic instability. 4. Routine use of pulmonary artery catheters not recommended. A diagnosis of ischemia and infarction, v. acute myocardial ischemia. 1. Identified by symptoms, signs, or ECG abnormalities. 2. Symptoms may be absent in perioperative setting due to anesthesia and analgesia. 3. ECG criteria. 22 contiguous leads with ST elevation depression or T wave inversion, IST elevation at the J point of at least 1 mm, depending on location, or IST depression of at least 0.5 mm, and or T wave inversion of at least 1 mm. V. Acute myocardial infarction MI, diagnosed by cardiac biomarker rise above 99th percentile limit with 21 of 1. Symptoms of ischemia. 2. New street segment T wave changes or left bundle branch block. 3. New pathological Q waves. 4. Imaging evidence of new loss of viable myocardium. 5. Identification of intracoronary thrombus. This criteria is not for peri-op settings. A myocardial injury after non-cardiac surgery, MINS. 1. Diagnosed by postoperative peak troponin T20.03 nml due to myocardial ischemia. VV management of myocardial ischemia. Confirmed diagnosis. 1. Obtain 12-lead ECG. 2. Consider echocardiogram if hemodynamic instability. 3. Obtain baseline and 4-hour troponin levels. Optimize myocardial oxygen supply and demand balance. 1. Pause surgery if necessary. 2. Achieve physiologic goals, low normal heart rate, normal blood pressure, oxygen saturation, avoid hypothermia. 3. Administer medications beta blockers, aspirin, GDN infusion. 4. Consider intra-aortic balloon, consider abandoning surgery, pump for failing heart. Multidisciplinary discussion based on patient stability and surgery urgency, consult cardiologist. 1. Emergent consultation for street elevation MI or hemodynamic instability. 2. Consider need for PCI thrombolysis usually contraindicated after surgical incision. Postoperative considerations. 1. Postoperative placement. Consider intensive monitoring and telemetry. 2. Serial ECGs and troponins if MI suspected. 3. Cardiology follow-up if infarct suspected. 4. Ensure good analgesia, euvolemia, and beta blockers to minimize tachycardia. 5. Maintain normal oxygen saturations. 6. Commence aspirin and P2Y12 inhibitor as guided by cardiology. Duchenne muscular dystrophy, background, X-linked recessive degenerative disease of skeletal and smooth muscle that usually first manifests in males of 2 to 5 years of age. Becker muscle dystrophy is essentially a milder form of Duchenne. Considerations: V. Airway, possible difficult airway if macroglossia. V. Gastrointestinal, aspiration risk, bulbar weakness, and gastric motility. Pulmonary: colon, possible obstructive sleep apnea, sensitivity to sedatives, hypnotics, pulmonary hypertension, RV failure, restrictive lung disease from scoliosis and respiratory muscle weakness, risk of perioperative respiratory failure, impaired cough reflex, atelectasis, recurrent aspirations, cardiovascular, dilated cardiomyopathy, tall R waves and precordial leads, R, S, deep Q and I, AVL, V5-6, mitral regurgitation common, due to papillary muscle involvement from 55 dilation. Conduction defects and arrhythmias common, atrial, SVT, AV nodal, VCNS, mild cognitive impairment is common, V-succinylcholine volatile anesthetics contraindicated due to rhabdomyolysis, hyperkalemia risk, use total IV anesthesia. Anesthesia management, Pre-op assessment, detailed HX and physical examination probing about all systems, airway CVS respiratory/0 say CNS previous anesthesia exposure, investigations, ECG echo, CBC infections, electrolytes, risk of rhabdomyolysis. X-ray ABGSPFTS, depending on severity of disease, scoliosis may also be present. Consultations, cardiology pulmonologue, preoperative preparation, inform family, obtain detailed informed consent. Avoid premedication, increased sensitivity to sedatives, hypnotics, aspiration prophylaxis, multidisciplinary approach. Cardiologist, pulmonologist, intensivist, AMD anesthetist, arrange ICU bed if severe respiratory disease or cardiomyopathy, anesthesia conduct, prepare according to anesthesia-related concerns and disease severity, airway, prepare difficult airway trolley, intra-op monitoring. 5-lead ECG, SP02, NIBP or invasive if cardiomyopathy, capnography, temperature, invasive monitoring may be needed in case of cardiomyopathies, peripheral nerve stimulator if NDNMBS used, induction, anesthesia technique, VRSI, modified RSI. Most preferred IV induction and IV maintenance due to their enhanced sensitivity to volatiles, cardiac plus rhabdomyolysis, V regarding neuromuscular blockers. Avoid SUX, absolutely contraindicated especially Duchenne, muscular dystrophy, risk of rhabdomyolysis and fatal hyperkalemia, cardiac arrest, V small doses of non-depolarizers may be needed. Use neuromuscular monitoring in such case. Regional technique? Depends on CVS status. In case of autonomic dysfunction and cardiomyopathy, severe hemodynamic instability can happen. In some patients with risk of respiratory depression, RA may be preferred and opioids avoided. V pre-warmed theater, active warming to prevent hypothermia, multimodal analgesia, paracetamol, peripheral nerve blocks, local infiltration, titrated. Opioids or opioid-sparing analgesia, extubation, if NDNMS used, nerve stimulator plus reversal to guide extubation, caution, respiratory complications are common, careful well-thought-off extubation plan. Based on severity of the disease or intra-op event, complications, rhabdomyolysis and hyperkalemia can happen, avoid triggers. Treat hyperkalemia, hydration. Management of rhabdomyolysis, respiratory failure needing prolonged ventilatory support, cardiac-related complications, arrhythmias, or cardiac failure, post-op, PICU bed, general ICU care with specific management focusing on ventilation, analgesia, warming, pediatric fluid management. You are asked to anesthetize a 6-year-old child who has acute appendicitis and has been unwell for the past 2 days. There are no significant findings in your medical or anesthetic assessment. What problems do you need to address in the perioperative period? The main issues are physiological effects of acute illness, dehydration and SIRS. Does the child need resuscitation prior to theater? Emergency anesthetic in a child, risk of aspiration, postoperative analgesia. How would you assess the degree of dehydration clinically? Calculation of water deficit due to dehydration using clinical signs is usually inaccurate and only gives an approximation of the true deficit. A history of vomiting, diarrhea, poor urine output, wet dry nappies in babies, and poor oral intake should be sought. Pediatric fluid requirements. Maintenance is calculated using the 4-2-1 regime. The fluid of choice is 0.45% sodium chloride, 5% glucose, AML/kgH, 100 ml/kgD. For each of the first 10 kilograms, 2 ml/kgH, 50 ml/kgD. For each of the second 10 kilograms, IML/kgH, 25 ml/kgD. For each subsequent kg. How would you assess the degree of dehydration clinically? Calculation of water deficit due to dehydration using clinical signs is usually inaccurate and only gives an approximation of the true deficit. A history of vomiting, diarrhea, poor urine output, wet dry nappies in babies, and poor oral intake should be sought. Date, assessment of dehydration, MAGAU, fluid loss expressed as AHE of body ut. 5. Dry, normal, none, S. Parkia blended, marked, 1 sbpm, markedly teed, vesi dry lingi, prisect, decreased, A. Mucous membranes, sensorium, orthostatic, changes I, HR, BP, rind put, metelli bed. 42 nat. High, Neumaltite, Neumal, pulse rate, blood pressure, LULMU, LBP, respectively. Vatialian, Pelodic. 4 IV, Tinical, HR, SBP, pulse val, capillary refin skin colloid, skin temperature, mutate status, RR, fluid loss, flood manephimet elield reguiremit on NNT2 paths, preoperative, ascens mute of, hypovolemia tediatias, mpensted, TED. Neumalted natmat bed, namal TD, pale, call, etided natmal TD, 251, LN kempensk TED, natmalted, ed, truersible, T-bed, TED, malial, cold, lethargic. 25-40 wide IRA, cold, unresponsive science, 40Y, dehydration in children, degrees of dehydration, 1. Mild dehydration 5%, signs of thirst restlessness normal skin turgor, heart rate, fontanelle, and moist mucous membranes, 2. Moderate to severe dehydration, 10%, evidence of shock, requires volume resuscitation, 20 ml kg boluses, fluid replacement calculation, 1. Deficit fluid replacement, estimated based on degree of dehydration e.g., 10% dehydration equals 100 ml kg, added to maintenance fluids over 24 hours. 2. Daily maintenance fluid requirement, 100 ml kg for first 10 kg, 50 ml kg for next 10 kg, 20 ml kg for each kg thereafter, if the child was 10% dehydrated clinically and weighed 20 kg. How would you calculate the fluid deficit? The formula is Wt, kg, x% dehydration x 10. Note, percent dehydration means 10 ml/100 gram weight. For this child, 20 x 10 x 10 equals 2000 milliliters. Fluid deficits should be replaced over 24 hours and added to maintenance fluids. What fluid would you use? Resuscitation, bolus doses of 10-20 ml kg of 0.9%, isotonic sodium chloride. Deficits infusion over 24 hours of 0.9% sodium chloride, maintenance minus 0.45% sodium chloride with glucose, 5% or 2.5%, or Hartmann's solution. Wouldn't you use 0.18%, 1/5? Normal saline with glucose 4%? No. This is a markedly hypotonic solution and risks hyponatremia. Hyponatremia is particularly problematic in the perioperative period, but also with a dehydrated, septic, head-injured or a chronically unwell child. The risks of iatrogenic hyponatremia have recently been highlighted by the National Patient Safety Agency. 1/5 normal saline should be reserved for specialist units such as cardiac or renal wards. What other considerations are there when it comes to fluid therapy? UNDs should be monitored at baseline and every 24 hours. Ongoing losses should be assessed every 4 hours. Glucose containing solutions should be administered to prevent hypoglycemia in the fasting child. Potassium should be added at up to 40 mol guided by UND results AMD once urine output is established. Enteral fluid administration should be considered regularly and instituted as soon as tolerated. General points for fluid replacement. Ongoing losses should be replaced with like-for-like fluids that reflect the electrolyte composition of the fluid being lost. V losses can usually be replaced with isotonic solutions with or without the addition of potassium. There is currently not enough evidence to recommend one glucose containing solution over another. 2.5% glucose, with 0.45% saline or Hartmann's, is probably enough to prevent hypoglycemia in the fasting child. V higher concentrations of glucose combinations are hyperosmolar and may require multiple cannulations or even central access for prolonged intravenous fluid therapy. How would you provide postoperative analgesia for this child? Multi-modal analgesia, paracetamol, 15 mg kg IV or 40 mg kg, PR, loading 15 mg kg maintenance 4 to 6 hourly max 90 mg kg per day, NSAIDs such as diclofenac 1 mg kg 8 hourly cautious use, as this child is already dehydrated. Opioids such as morphine 0.15 mg kg IV 0.3 mg kg PO2 to 3 hourly, wound infiltration with local anesthetic bupivacaine 0.25%, up to 2 mg kg, antiemetics, combination therapy would be reasonable in this case. ondansetron 0.15 mg/kg, dexamethasone 0.15 mg/kg. Fluid requirements. Fluid requirements in infants are greater than in adults or older children because of their higher metabolic rate and their greater surface area to weight ratio. This results in higher insensible water loss. The reduced renal concentrating capacity also results in increased obligatory water loss. Fluid management. Neonates. 80% of neonatal total body weight is water. The value is higher in the preterm infant and reaches an adult level of 60% by 2y. Extracellular water constitutes 45% of TBW at term, over 50% in the preterm but attains an adult value of 35% by early childhood. Plasma volume tends to stay constant at 5% of total body weight, independent of age. Turnover of water is over double that of the adult. 40% of extracellular water is lost daily in infants as urine, feces, sweat and insensible losses. A small increase in loss or reduction in intake can rapidly lead to dehydration. Daily fluid maintenance is calculated from the calorie requirement. 100 kcal/kg for the infant, with older children requiring 75 kcal/kg, and adults 35 kcal/kg. Each kcal requires 1 milliliter of water for metabolism. Neonatal fluid requirements. Fluid is initially given cautiously, as the kidneys cannot easily excrete a water or not plus load. Newer cold light phototherapy does not require increased fluid intake. The fluid of choice is 10% glucose. This is adjusted in increments of 2.5% to achieve normoglycemia. A blood sugar below 2.6 mol/L is treated with 2 ml/kg of 10% glucose. Routinely added electrolytes are Na plus 3 mol/kg and K plus 2 mol/kg. Other electrolytes, including Ca2+, are added as indicated. The first 5D of neonatal fluid requirements are given in Table 3.6. 1 may be proportionally higher. Preterm requirements are dependent on birth weight and perioperative fluid management. Pediatric components. 1. Basic maintenance requirement. 2. Replacement of observed fluid losses. Fluid choices. 1. Isotonic crystalloid. 0.9% sodium chloride or Hartmann's solution. 2. Albumin or blood according to clinical need. 3. Glucose-containing solutions for neonates and infants, e.g., 1% or 2.5% glucose in Hartmann's solution. Blood transfusion. 1. Trigger. 15% blood loss or HB70gl. 2. Calculate estimated blood volume EBV, and maximal allowable blood loss MABL, preoperatively. 3. Monitor blood loss swab weighing, suction volumes. 4. Consider cell salvage for children, 10 kilograms, maximal allowable blood loss calculation, MABL equals, HB initial, HB low x EBV, postoperative fluids. 1.0.45% sodium chloride 5% glucose, or Hartmann's solution for children, 8-10 years. Shock. Definition: inadequate delivery of oxygen and metabolic substrates to meet cellular demand. Stages of shock. 1. Compensated shock, maintained oxygenation of vital organs, brain, heart. Sympathetic reflexes redirect blood flow from non-essential tissues, normal blood pressure, increased systemic vascular resistance, SVR. 2. Decompensated shock, hypotension develops, vital organ perfusion compromised. 3. Irreversible shock, cyanosis, bradycardia, gasping respiration, preterminal event. Causes of shock, asked in Viva. 1. Hypovolemic shock, most common in children. 2. Cardiogenic shock, pump failure. 3. Distributive shock, sepsis, anaphylaxis, neurogenic. 4. Obstructive shock, cardiac tamponade, tension pneumothorax, assessment of dehydration and hypovolemia. Clinical signs. 1. Early signs: capillary refill time 2 seconds, cold and blue peripheries, increasing peripheral temperature, gap, thready pulse. 2. Late signs: oliguria, reduced level of consciousness, hypotension, occurs after 35% blood volume loss. Management. 1. Fluid boluses. 20 ml/kg crystalloid, 0.9% sodium chloride or Hartmann's solution. Reassess after each bolus. 2. Blood transfusion, when 15% of circulating volume is lost, if no improvement after 40 ml/kg fluid resuscitation, aim for HB of 70 g, lower PCV of 25%. 4 ml/kg blood raises HB concentration by 10 gl. Monitoring. 1. Arterial or SP02 trace swing can indicate intravascular volume loss. 2. Central venous pressure, CVP, may be less sensitive in smaller children. Solution: osmolarity sodium content, mosmol, MEC 308, 432, 154, 75. Osmolality, compared to plasma, isosmolar, tonicity, 0.9% sodium chloride, 0.45% sodium chloride with 5% glucose, 5% glucose, 0.9% sodium chloride with 5% glucose, 0.18% sodium chloride with 4% glucose. Hartmann's solution: isotonic, hyperosmolar hypotonic, isosmolar, hypotonic, hyperosmolar isotonic, isosmolar, hypotonic, isotonic. 278 586, 284, 150, 31, 278. 131. Isosmolar, problems of the premature baby. Julian, a 10-week-old female infant weighing 3.5 kilograms is scheduled for inguinal hernia repair. She was delivered prematurely at 34 weeks. What would you inquire about specifically in your preoperative assessment? A detailed history from the parents and the notes is required, particularly if the child spent any time on the neonatal ICU, details of any previous operations, time spent on a ventilator, any medical conditions or congenital problems diagnosed, general health since leaving hospital, putting on weight, feeding-associated breathlessness, special precautions or procedures required, egg NG feeding, handling, any medications, including oxygen therapy. Premature babies are defined as those born before 37 weeks gestation and account for about 13% of UK births. They are susceptible to the following: increased risk of congenital abnormalities, especially small for dates babies, hyaline membrane disease, bronchopulmonary dysplasia, patent ductus arteriosus, intraventricular, brain hemorrhage, retinopathy of prematurity, hypoglycemia, anemia, increased susceptibility to infection, lack of thermoregulation. What potential problems are there in anesthetizing her? A difficult airway should be suspected if there has been prolonged intubation. This may be subglottic or be part of a congenital abnormality. Previously ventilated neonates can have poorly compliant lungs. Adjust ventilation to minimize high airway pressures. Avoid high Phi02. Fluctuations in blood pressure should be avoided to minimize the risks of hypoperfusion and resultant ischemia, and hemorrhagic cerebral injury. Venous access may be difficult after prolonged IV access in NICU. Drug metabolism may be impaired due to immature liver and enzyme systems. Drug elimination is impaired due to immature renal function. Hypoglycemia should be avoided by minimizing the starvation time, administering glucose containing IV fluids, regular monitoring of the serum glucose concentration. Meticulous attention should be paid to maintaining normothermia. The general problems of anesthetizing a baby also apply. See box. What precautions would you take postoperatively? Postoperative apnea is a common problem. Apnea is significant if 15 seconds or if associated with cyanosis or bradycardia. An apnea alarm is mandatory in the postoperative period. Caffeine 10 mg/kg on induction reduces the incidence by 70%. CPAP may be helpful by distending the chest wall and triggering stretch receptors. How would you provide postoperative analgesia? The principles of multimodal analgesia should be used. However, avoid opioids if possible due to apnea risk. NSAIDs should be used with caution as they reduce renal function by up to 20% and may affect ductus arteriosus closure in the very young neonate. Paracetamol dosing intervals are extended due to reduced metabolism. Paracetamol is given at a dose of 15 mg/kg 8 hourly. General considerations when anesthetizing a baby airway. The airway is prone to obstruction because the head is relatively large with a prominent occiput, and the tongue is large. Infants and neonates breathe mainly through their nose. The epiglottis is large, floppy and U-shaped. The trachea is short. Endobronchial intubation. The glottis is more anterior and the narrowest part of the airway is at the cricoid ring. Respiratory, ventilation is diaphragmatic and rate dependent. Horizontal ribs reduce mechanical advantage. Closing capacity encroaches into FRC during tidal breathing. Increased airway resistance. 50% nasal. Cardiovascular, rate dependent cardiac output. Poor ventricular compliance, low SVR, high vagal tone, gastrointestinal, immature enzyme systems until 12 weeks, alter drug handling, prone to hypoglycemia, renal, functionally immature, altered sodium and drug excretion, poor thermoregulation, high surface area, volume ratio and minimal fat. Some other definitions: neonate first 44 weeks post-conceptual age, premature infant less than or equal to 37 weeks gestation, neonate's first month of life, infants 1-12 months, low birth WT less than or equal to 2.5 kilograms, a pediatric day case surgery. Julian, you are asked to anesthetize a fit 3-year-old child for circumcision as a day case. Is this an appropriate patient for day case anesthesia? Yes, provided the child has a suitable social setup and no potential issues with general anesthesia. Suitability for day case may be assessed on 4 areas: patient factors, either fit and well or well-controlled systemic diseases such as asthma, age, 50-60 weeks post-conceptual age if preterm due to apnea risk, absence of active viral or bacterial infections, particularly respiratory tract infections excluding isolated runny noses, as this is usually benign seasonal rhinitis and is very common. The presence of respiratory tract infections should result in deferral of surgery for 2-4 weeks to reduce the risk of intraoperative laryngospasm, bronchospasm and postoperative hypoxia. Absence of undiagnosed murmurs should be investigated preoperatively, or significant congenital heart disease. Absence of diabetes mellitus. Surgical factors: duration 1 hour, surface or laparoscopic procedures. Minimal anticipated blood loss, anticipated postoperative pain controllable with simple analgesics. Anesthetic factors: absence of known anesthetic problems such as difficult airway or family history of MH. Social factors: adequate parental support, cooperation and understanding of instructions, telephone in home or nearby, access to transport and proximity to hospital, 1 hour away. The child with a cold. It is very common to have a child with a runny nose. Probably okay to continue if the child is at the end of a cold, is constitutionally well and has a normal temperature and no chest signs. Otherwise postpone. Increased risk of laryngospasm, bronchospasm, airway secretions and airway obstruction. Postpone for 2 weeks for inertia and 4 weeks if lower respiratory tract signs are present. What would be your lower age cutoff for day case anesthesia? Preterm infants with post-conceptual ages less than 50-60 weeks are unsuitable for day case because of increased apnea risk in the postoperative period. Some centers will not accept term infants below this age while others will consider term infants for minor procedures. What premedication would you consider using in pediatric day case? Cutaneous local anesthesia with EMLA, eutectic 2.5% lidocaine and 2.5% prilocaine, or amidop. 4% tetracaine gel. Tetracaine was previously known as emethicaine in the UK, hence the name amidop. EMLA should be applied 1h before cannulation and is unlicensed below 1 year. Amidop has a more rapid onset and may be applied 45 minutes before cannulation. It is not recommended below 1 month of age. Profoundly anxious children or those with behavioral or learning difficulties may require sedative premedication. Midazolam 0.5 mg/kg orally or nasally will usually result in adequate sedation if given 30-45 minutes prior to induction. While postoperative sedation is seldom a problem, it may occur. Other traditional sedatives result in too much postoperative sedation to be used in day case. Simple analgesia may be given preemptively as a premed. What anesthetic agents would you use in pediatric day case? Induction with either intravenous propofol, 2.5 to 4 mg/kg, or inhalation with sevoflurane are acceptable techniques. Thiopentone may result in delayed recovery. Maintenance with a volatile agent in oxygen air or oxygen nitrous oxide may be used and facilitate spontaneous breathing. The use of nitrous oxide in day case has not been shown to increase the incidence of PONV in children. Sevoflurane offers rapid emergence and is well tolerated, though, in short procedures there is not likely to be a benefit in terms of discharge time compared with isoflurane that justifies the extra cost. Desflurane has been advocated due to rapid wake-up but may cause airway irritation and coughing in spontaneously breathing patients. Tiva with propofol may be of use if PONV is anticipated. What analgesics would you use in pediatric day case and how would you administer them? Paracetamol may be given orally as pre-med, single loading dose of 20 mg/kg if aged over 3/12 or 15 mg/kg below, rectally single dose of 40 mg/kg, or intravenously, 15 mg/kg. NSAIDs are suitable agents for day case and ibuprofen 5 mg/kg orally preoperatively or diclofenac 1 mg/kg orally or rectally are the most commonly used. The majority of children with asthma do not have NSAID sensitivity, the exception being those with nasal polyps. Opioids may produce significant sedation and PONV. Ideally, only short-acting agents such as fentanyl, 1-2 mg/kg IV, or weak opioids such as codeine 1 mg/kg orally should be considered. Local anesthetic blocks may reduce or obviate the need for opioids. How would you anesthetize this child? Preoperative. Full anesthetic history from the parents including fasting status and examination of the child including weight measurement, explanation and consent for penile block under general anesthesia and consent for rectal analgesia. Cutaneous anesthesia with EMLA or amidop on the ward and calculation of drug doses, preparation of emergency drugs, atropine 20 mg/kg and succinylmethonium 1.5 to 2 mg/kg, induction. Full anesthetic monitoring, IV induction with propofol or inhalation with sevoflurane if cannulation is difficult. Insertion of LMA, analgesia, penile block after induction. IV paracetamol and diclofenac, maintenance, spontaneously breathing on sevoflurane and oxygen air mix, or oxygen nitrous oxide. Intravenous fluid if prolonged starvation, either 10 ml/kg bolus or calculation of deficit and replacement. Some anesthetists advocate prophylactic antiemetics, particularly in high-risk patients. Suitable options, ondansetron 0.15 mg/kg and dexamethasone 0.15 mg/kg. Emergence. 100% oxygen in left lateral position. Discharge criteria postoperatively. Stable vital signs. Pain and nausea controlled. Able to pass urine and drink fluids. What other blocks may you consider? An alternative to a penile block would be a caudal block. The potential problems with a caudal in an ambulatory child would be temporary leg weakness and the risk of urinary retention, which may delay discharge. Explain how you would perform a penile and caudal block. Penile block. Take consent from the parents. Full preparation with trained assistant and resuscitation equipment available. Calculate toxic dose of local anesthetic to prevent overdose. Bupivacaine or levobupivacaine 2 mg/kg. Adrenaline-containing local anesthetics must be avoided. After induction of anesthesia, leave the patient in the supine position. Full asepsis with skin preparation. Palpate the distal symphysis pubis. Pass a 21G block needle just distal to the palpating finger. When the needle contacts the distal edge of the symphysis pubis, it should have passed through Buck's fascia and be in proximity to the dorsal nerves of the penis. After careful aspiration, inject local anesthetic. Bupivacaine 0.5% 1 ml plus 0.1 ml/kg. Some advocate performing injections either side of the midline because of a possible midline septum. The block is completed by subcutaneous injection across the base of the penis. Bupivacaine 0.5% 2 ml. Caudal block. Take consent from the parents. Full preparation with trained assistant and resuscitation equipment available. Calculate LA dose to be delivered. According to the regimen of Armitage, this would be 0.5 ml/kg of bupivacaine 0.25% for a lumbosacral block. After induction of anesthesia, place the child in the left lateral position. If a right-handed approach, full asepsis with skin preparation. Locate the sacral hiatus. Defect due to failure of the fusion of the fifth and sometimes fourth sacral laminae. The sacral hiatus may be located by The sacral hiatus forms the apex of an equilateral triangle with the posterior superior iliac spines. B. Place your index finger along the curve of the sacrum in the midline with the tip on the tip of the coccyx. Withdraw the finger cephalad until a depression is felt. In both techniques, the sacral cornua can be palpated. Just cephalad to the sacral hiatus. Insert a 22G cannula at 45 degrees, aiming cephalad until a click is felt. Bring the cannula to a more shallow angle approximating the long axis of the spinal column, and advance the plastic cannula forward a short distance. The dural sac may terminate at S2 or lower. Careful aspiration for blood or CSF should be performed before injection of local anesthetic. If resistance is encountered or swelling occurs, injection should be terminated and the cannula should be repositioned. Regimen of Armitage for caudal blocks: 0.25% bupivacaine, volume based on weight and the level to be blocked. Lumbosacral block up to L1-0.5 ml kg, block up to T10 1 ml kg, block up to T6 1.25 ml kg. It can be seen that the higher blocks use more than the suggested maximum dose of bupivacaine of 2 mg kg. However, this is a well-recognized and widely used formula. Remaining topics, combine with Dr. Mariam's handwritten notes. Surgery, general considerations, airway management. 1. Shared airway, surgeons and anesthetists share access. 2. Potential issues, airway obstruction, equipment displacement or damage, bleeding into airway, postoperative swelling, collaboration and priorities. 1. Team planning, surgeons around anesthetists plan together. 2. Airway priority, correct airway problems immediately, even if surgery needs to be stopped. Additional considerations. 1. Protect surrounding structures, especially eyes, using tape and padding. Surgery, airway ventilation management, airway options. 1. Tracheal tube, traditionally used for airway protection. Preformed ray tubes minimize intrusion into surgical field. 2. Laryngeal mask airway LMA, alternative approach, adequate protection against aspiration, restricts surgical access and prone to displacement. Ventilation options. 1. Spontaneous ventilation SV, allows titration of analgesia, improves success for deep extubation techniques. 2. Intermittent positive pressure ventilation, PPV, often used with remifentanil opioid infusions, can be used with ETS or LMAS, anesthetic techniques. 1. Total intravenous anesthesia TIVA, commonly used for spontaneously ventilating patients. 2. Multiple induction techniques, available. Extubation techniques in surgery. Considerations. 1. Bleeding into the airway, suctioning and pack removal under direct vision essential. 2. Hidden blood accumulation, nasopharynx behind soft palate clear with nasal suction, catheter or Yankauer sucker. 3. Coughing and bleeding risk, consider when selecting extubation technique. 4. Laryngospasm risk, minimized by extubating deep or light, a deep extubation. 1. Suitable for spontaneous ventilation SV or supported SV. 2. Technique, continue increase anesthetic agent, switch to 100% 02, suction, insert Goodle airway, turn patient left lateral head down, tonsil position, extubate when respiration is regular. 3. Post-extubation care, monitor airway respiration, keep patient in tonsil position until airway reflexes return. Skilled recovery staff essential, be light extubation. 1. Recommended for difficult airway or significant respiratory compromise. 2. Technique, suction, reverse NMB, discontinue anesthetic agents, extubate when laryngeal reflexes return. 3. Post-extubation, brief coughing restlessness common, opioids may reduce coughing frequency, throat packs in surgery. Purpose. 1. Absorb blood in upper airway. 2. Useful during nasal and dental surgery. Key considerations. 1. Must be removed before extubation to prevent airway obstruction. 2. Systems to ensure removal, tying taping pack to ET, identification sticker on ET or forehead, inclusion in scrub nurses count, standardized removal protocol. 3. Direct laryngoscopy before extubation recommended, nasal vasoconstrictors. 1. Reduce bleeding in nasal surgery. 2. Options, cocaine-containing solutions max 3 mg kg, pseudoephedrine, phenylephrine. 3. Systemic absorption can cause sympathomimetic response. 4. Adrenaline infiltration may increase systemic effects. Remifentanil. 1. Used for major cases. 2. Applications: middle ear surgery, major head and neck resections, parotidectomy, laryngoscopy, pharyngoscopy, nerve monitoring procedures. 3. Considerations: bradycardia, hypotension risk, interpatient variability, prevent postoperative rebound hypertension, agitation with low-dose remifentanil or longer-acting opioids, radical neck dissection, procedure, excision of sternomastoid, internal and external jugular veins and associated lymph nodes. Modified or selective neck dissection preserves some of these structures, notably, internal jugular vein, time duration, 2-4H, pain plus, selective neck dissection plus, position, supine, pad under shoulders, head on ring tilted to side, head up tilt, blood loss moderate to substantial, X-match 2-4 units. Practical techniques, IPPV, ET with tubing going north or south, facing ray tube on opposite side. Arterial line, urinary catheter, CVP line if surgery likely to be long, complicated or with cardiac disease. Preoperative, assess airway carefully, as may be an associated head and neck tumor or previous major surgery, may be performed with another procedure, e.g., laryngectomy. Perioperative, forced air warming blanket and fluid warmer, long tubing is needed for the breathing circuit and gas sampling. Remifentanil infusion IDL, can bleed briskly from large neck vessels, with substantial accumulation of blood under drapes, may not be apparent until end of case. For CVP access, femoral is best. Must avoid remaining jugulars, as head and neck venous drainage dependent on them. Postoperative, head and neck edema likely for several days, impaired venous drainage. Keep head up as much as possible, and avoid excessive IV fluids, to reduce chance of agitation, rebound hypertension and wound hematoma in recovery. Continue remifentanil at a low infusion rate, or give morphine 15-20 minutes before end of surgery. Clonidine up to 2 mcg kg IV or dexmedetomidine also very useful. Treat any hypertension early. Analgesia with PRN, paracetamol or NSAID POVPR, morphine POIV. Surprisingly low analgesic requirements normally, antiemetic, as required. Special considerations: beware of air emboli during dissection, early detection by sudden fall in echo 2, surgical manipulation of carotid sinus can produce marked bradycardia. If neck dissection previously done on other side, edema is usually worse and can raise ICP. Dexamethasone 8-12 mg IV preoperatively, then 4 mg IV 6-hour lie, is used by many to reduce this. Assessment of airway obstruction: refer to detailed article summary for airway obstruction. Causes: 1. Tumors, adults. 2. Infections, croup, epiglottitis. 3. Foreign bodies, children. 4. Hematoma, signs and symptoms. 1. Stridor, high-pitched, inspiratory. 2. Respiratory distress. 3. Long, slow inspirations. 4. Recent deterioration in exercise tolerance. 5. Worsening stridor during sleep. Assessment tools: 1. Radiographs, plain films, CT, MRI. 2. Clinic flexible or indirect laryngoscopy. Management: 1. Emergency intervention for life-threatening obstruction. 2. Determine time-critical airway management. 3. Holding measures: high-flow nasal oxygen, steroids for edema, inflammation, nebulized adrenaline, helium, heliox, continuous positive airway pressure, CPAP. Investigations: 1. Nasendoscopy. 2. CT rapid assessment, 3D reconstruction. 3. MRI gold standard for soft tissue imaging, but limited practicality in acute setting. Securing airway access in obstructed airway. Main problems: 1. Worsening airway obstruction due to positioning, GA, or instrumentation. 2. Difficulty identifying laryngeal inlet due to anatomical distortion, secretions, or blood. 3. Passage of tube challenging due to severe stenosis. Techniques: 1. Direct laryngoscopy and intubation under deep inhalational anesthesia, SV. 2. Awake fiber optic intubation, AFOI, under local anesthesia, LA. 3. Tracheostomy under LA or deep inhalational, GA. Considerations: 1. Prepare full range of equipment, including different laryngoscopes and cricothyroidotomy kit. 2. AFOI useful for supraglottic lesions, but may not be suitable for stenotic lesions. 3. Deep inhalational anesthesia may be slow, but CPAP can help keep airway patent. 4. In children, deep inhalational anesthesia is often the only realistic option. V. Emergency situation. 1. If complete airway obstruction occurs and conventional attempts fail, emergency surgical access is necessary. 2. Surgical cricothyroidotomy is preferred over tracheostomy due to speed, superficiality, and reduced bleeding risk. Jet ventilation. Description. 1. High-pressure gas delivery into an open airway. 2. Passive exhalation. 3. Significant risks due to unfamiliarity and potential misplacement. Types. A. Low-frequency jet ventilation. Description. 1. Manually driven injector system e.g., Manujet. 2. Delivers high-pressure gas jet into airway. Methods. 1. Cricothyroidotomy needle cannula, placed through cricothyroid membrane under local anesthesia, aimed towards carina. 2. Jet catheter, rigid, non-compliant catheter, tip placed midway down trachea. 3. Injector needle, attached to operating laryngoscope rigid bronchoscope. Ventilation starts when aligned with larynx trachea. Considerations. 1. Risk of catastrophic consequences if cannula misplaced misdirected. 2. Inadequate gas exchange common. 3. Technique requires experience and caution. B. High-frequency jet ventilation. Description. 1. Specialized ventilators deliver high-frequency gas jets, 110 Hz. 2. Warmed and humidified inspiratory jets. 3. Electronically controlled. V. Key features. 1. Adjustable parameters, frequency, driving pressure, inspiratory time, gas composition. 2. Air entrainment, delivered 5 a second vary. 3. Monitoring, airway pressures, cutoffs and safety features, inspiratory pauses for accurate C02 sampling. Benefits. 1. Effective ventilation with smaller tidal volumes. 2. Useful in airway surgery and lung protective strategies. Considerations. 1. Requires experience and specialized equipment. 2. Careful monitoring and adjustment of parameters. Indications of jet ventilation. 1. Emergency airway management, transtracheal cricothyroid membrane cannula. 2. Airway surgery, laryngeal tracheal stenosis, major conducting airway surgery. 3. Thoracic surgery, lung isolation techniques. 4. Lung protective ventilation strategies in ICU. Safety considerations. 1. Monitor airway pressures. 2. Cutoffs and safety features. 3. Inspiratory pauses for accurate CO2 sampling. Parotidectomy, procedure excision of parotid gland, usually preserving facial nerve. Time duration. 2-5H. Pain, +++++. Position, supine, head ring, head tilted to side and moderately extended, head up tilt blood loss, small moderate, G and S. Greater for malignancy. Practical techniques. South-facing ray tube and IPPV normally used, though SV possible for suitable patients. Reinforced LMA and IPPV or SV also possible. No NMB during dissection around facial nerve. Anesthesia for parotidectomy. Preoperative. 1. Assess suitability for spontaneous ventilation SV. 2. Check mouth opening, especially if malignant. Perioperative. 1. Forced air warming blanket, fluid warmer, and urinary catheter as needed. 2. Avoid NMB after initial dose to allow facial nerve testing. 3. Remifentanil infusion ideal for PPV without NMB and reducing blood loss. 4. Alternative, suppress respiratory drive with opioids, volatile agents, or propofol infusion. 5. LA spray to larynx to prevent coughing. Postoperative. 1. Continue remifentanil or give morphine before end of surgery to prevent agitation and hypertension. 2. Keep head up and treat hypertension early. 3. Antiemetic and analgesia is required. Special considerations. 1. Surgeon may use nerve stimulator to identify facial nerve. 2. Large bore IV access recommended due to potential bleeding. Nerve blocks. Oxford, a cervical plexus block. V. Indications. 1. Analgesia or anesthesia for carotid surgery and superficial neck procedures. Positioning. 1. Lateral or supine with head turned to contralateral side. Technique. 1. Ultrasound-guided intermediate block of superficial cervical plexus nerves. 2. Identify C7 and C6 transverse processes, then C5 and C4. 3. Block usually performed at C4 level. 4. Identify lateral border of sternocleidomastoid muscle SCM. 5. Target plane between deep border of SCM and deep cervical fascia, prevertebral fascia. 6. Insert needle in plane from posterior, infiltrating the plane and surrounding nerve-like structures. Landmark technique for cervical plexus block. 1. Injection point, midpoint of posterior border of sternocleidomastoid muscle SCM. 2. Inject 10-15 ml local anesthetic fan along posterior border of SCM, cephalad and caudad. Side effects: ultrasound-guided intermediate block of superficial cervical plexus. Nerve blocks, Oxford, a cervical plexus block. V indications.